Edentulous patients teach us a lot about occlusal stability and the effects of the occlusion in the cervical structures, also as the mechanisms of function and the symptoms related with the patient. When we have these conditional patients that the occlusal is unsupported, that we can see is no posterior support, and the proprioception of the patient is trying to make those anterior teeth get in contact, but with all this on posterior support, is a chance that those joints they're gonna have problems and it's gonna be affected. In these particular patients, the research is focused to understand why this patient has pain in the left side, and we check internally the articulation, and we can see that is a lack of space in the posterior region of the condyle and the temporal bone. If we compare with the other side, we can see that we have a slightly more space, and the patient refer difficulties when they open the mouth, mostly in this specific area. During the plan of the treatment, the idea is to try to decompress those joints to understand what is the new mandibular position, what is going to be the biofunctional position to reestablish the patient, even in a phase before we start placing implants. If we can see in reference with the occlusion, for instance, we can see that the open midline intercept half of the tooth over here. We're going to use this just as a visual reference to understand how it's going to be the mandibular movement. When we compare the two situations, in this case that we took a biofunctional bite into the patient. In order to do that, we went to our in-lab software and we designed a partial frame in the partial software where we're able to use it to transfer the bite. So this part is mill, and we were able to put bite registration into to create posterior support and get the bite registration. This is how the device looks like. Basically, we just have a partial frame, just as it shows in the video, and we have the bite registration that we use to talk a bite and create the proper ingrams and the proper occlusion. In this particular case, we notice that the occlusion into the patient is all forced into the anterior segment. And that's why we having some discrepancy into the occlusion. So if we come back to the comparison mode, when we can see the changes in the structures, we will see what happened with these joints. This is the preliminary scans, and this is the after that we found the bite, and we notice that in the right side, the changes into the joints are not as dramatic as in the other side. We put a little more density, so we tell us that that condyle was in that bad shape. But when we see the other side and we compare the preliminary analysis into the fossa, and this is the condyle that they didn't have a space, we notice that after that we decompressed the joints and we did some manual therapy in the cervical spine and relaxation of the muscles, that condyle decompressed here, and that's why we have more space. Again, we compare the post-op after the bite and then the pre-op. They determined that it's not a hinge rotation, and that in many cases, mostly the dysfunctional cases, it's not ideal to try to manipulate the jaws or even open the bite into the articulator. If we check the relationship between the teeth that we talk in the preliminary area here, we can see how the midline is intercepting half of the tooth, and in the other side we can see that the midlines are aligned. Not because we're trying to look any alignment of midlines as any reference. The muscle function want to be there. But when we analyze the details, why this patient is creating that factor, we can see that the patient has the need to shift to this side because the patient has an interference in function into that canine against to that lateral. So that definitely will affect in the parallel closure. Big part of this craniocervical analysis has an enormous value because we can see what happened to the cervical spines. Cervical patients that they have dysfunction and they have collapse into the occlusion. And it's important that we understand why this collapse occurs, how a patient can lose vertical dimension. As we can see here in the preliminary picture, this premolar has been migrated mesially, what it makes that will look vertical high, what automatically we will compress that temporomandibular joint, creating discrepancies in the space. In the biofunctional dynamic concepts, after that kinematic analysis using CCAT function, CCAN add a GMT jaw tracking, we can see exactly the behavior of the joints in dynamics, so we can determine that this mandibular position was ideal. At this point, the patient is not in full treatment with manual therapy or therapies. We will try to take care about the cervical spine. We can see how the cervical spine is highly compromised, and we can see how all the vertebrae, like this is the foramen magnum, the first vertebra, this is the second vertebra, and we can see how the spinal bodies of these vertebrae are misaligned and displaced. The second vertebra is the vertebra that allows the side bending of the head. So in this particular patient, when we have this joint that is compressed because the patient loses vertical height into this side, this forces the patient to have a side bending pattern that we will make to create that apophysis of the C2 will move to the opposite side. That's a really differential diagnostic to understand when the occlusion is affecting the patterns in dynamics. So we're going to continue with this case. More data will be presented. This is one of the 30 cases that we presented for a research with Sirona about the influence of translation and rotation and how the patients are totally different into the kinematic movements. How we need to determine that the body is not a hinge at rotation, and all the functional patterns and physiologic situations like this patient that loses posterior support by misocclusion is creating a direct relationship into the cervical spine. This is just a few other steps how we can integrate technology in lab, the software for partials, and how over this transfer by that we create, we're going to continue with the in-lab software, and we're going to produce a partial that is going to be impacted material, that is going to have more resistance and going to have some occlusal stability to help the dysfunctional patients. The patient is going to be with manual therapy techniques for about 6 weeks before we create a refinement of the occlusion, and then when we have this stable, we will start planning the second phase, that is going to be the implant phase. Thank you for watching. I think that these subjects are interesting since we revolution the concepts in dentistry, because we understanding that we not function as a hinge axial rotation, that we are a little more complex, and technology today allows to use these tools to have more predictable restorations. Thank you so much.